Hey everyone. Okay, so I'm in the I'm in the rainforest, living in a little house with like seven other people. So if you hear any weird sounds, I don't know. That explains it. Let's talk about oncology. So specifically with an emphasis on leukemias, lymphomas, things like that. All right, so we're just going to do a little introduction to cancer, and then we're going to talk about just an overview of all of the specific proliferative disorders, emphasizing the myeloproliferative disorders and the plasma cell dyscrasias, then the leukemias, lymphomas, and then a final video with the chemotherapeutic agents. Some cancer basics. So the general outline of this first video, this first chapter, just a little some nuts and bolts of cancer, the 10 hallmarks, which is based off of this famous paper we'll talk about. A lot of nomenclature, different types of carcinomas versus sarcomas, specifically cancer-causing agents, whether this be genes, carcinogens, or different pathogens, and then specifics about staging, tumor markers, different stains we can do, and then we're going to wrap up with a little bit on paraneoplastic syndromes. All right, so cancer takes a long time to develop, usually, right? Some cancers might develop really quickly in a year, some might take 20 years, but on average it takes a couple of years. So, you have a normal cell, is a genetic change, and then maybe it divides a little bit more than it used to. Another genetic change, and now maybe it doesn't proofread the DNA as well as it used to. Another genetic change, maybe now it can break through the basement membrane, and et cetera, and then maybe a final genetic change to allow it to invade into a new foreign region, and then we might say that it's a malignant tumor. So it takes a long time and a lot of gene mutations typically. So at least a couple. We might say about 6 on average, but several changes takes a long time. Specifically, signs of cancer: fever, night sweats. Cancers secrete pyrogens. Weight loss, also known as cachexia, if it's extreme. Cancer cells divide a lot, right? That's the whole point of cancer, is that it just divides uncontrollably. This takes a lot of energy to replicate the DNA and everything inside of the cell. They're also really inefficient with their energy. So the Warburg effect refers to the idea that cancer cells don't really do aerobic respiration. They just do glycolysis. If you recall, we get a measly 2 ATP with a glycolysis, and we get something like 30 to 32 ATP when we do aerobic respiration. So they're crazy inefficient on top of needing a lot of energy, meaning that they're going to divert a lot of the resources that go towards you towards the cancer. And so you might become frail and the cancer enlarges itself. Additionally, the TNF, tumor necrosis factor alpha, induces catabolic activity in nearby areas. So this is kind of an interesting, complex relationship between the immune system and TNF and cancers. So on the one hand, TNF is supposed to be, in other inflammatory mechanisms are anti-cancer, but weirdly they're also utilized and co-opted by the cancer to facilitate cancer growth. And this is very complex and beyond the scope. But in this case, the TNF is facilitating and helping break down nearby tissue to feed the cancer. So the hallmarks of cancer was the seminal paper by Douglas Hanahan and Robert Weinberg in 2000. Just to show you how important it was, it's got 37,800 citations. Every 11 years, they basically done a revision to this paper. So 2011 was the newest paper, 57,800 citations, and they just came out with a new one. Only 6 citations, but it was literally just published, so probably not a lot of people have had a chance to subsequently cite it in their particular paper. So our understanding of cancer is constantly progressing. We're really going to be emphasizing the 2011, which has the 10 hallmarks, but so 2000 paper was the original 6 hallmarks. I highly recommend it if anybody is interested at all in oncology to read these papers. They're fantastic. 2011, they added 4 more. And then in 22, they've added another 4. So there's 14 now, but you know what? For your test, for your NBME, you just need to be familiar with these 10. So sustaining proliferative signaling just means oncogenes. Oncogenes turn on, pushing the cell cycle forward. Things like MYC, RAS, cyclin, CDK, receptor tyrosine kinases, these get upregulated. Next, we have basically inhibiting tumor suppressors, right? The cell cycle breaks, like the retinoblastoma protein, and P16, things like that. These are going to be downregulated and inhibited. Avoiding the immune system, so CTLA and PDL, which we will talk about later. So we can induce CTLA on T cells, or the cancer cells themselves can upregulate PD for programmed death ligand, which can turn off the immune system. Most cells have something called a Hayflick limit, so their telomeres get shorter and shorter and shorter. This kind of acts like a fuse for a bomb, which will eventually cause the cell to self-destruct. So maybe a cell has 50 divisions or so, and then it's no mas. But the cancer cells figure out a way to elongate the telomeres. Typically, this is by upregulating telomerase. So the telomeres don't actually get shorter, and therefore they can replicate as long as they want. So we just talked a little bit about the TNF secretion. They can either secrete TNF themselves, or more likely they will go ahead and manipulate nearby immune cells to be part of the tumor microenvironment to secrete tumor necrosis factor. The loss of cadherins is going to loose intercellular junctions so that the cancer cells don't necessarily have to be so close together. And on top of that, the metalloprotease is going to help them break through the extracellular matrix, break through the basement membrane. This is going to be necessary to get out of the local area into the lymph, into the blood, and into the new, the new organ that they're invading. Angiogenesis tumors, they need a lot of resources, so they need a lot of blood coming towards them. This is really just VEGF. So cancers like to have mutations. Mutations helps them adapt, helps them evolve. Things like BRCA for double-strand breaks, and MSH for this would be specifically for I believe this is microsatellites. I could be wrong, but microsatellites and just missense mutations that are recognized. These will get mutated so that the cancer cells can just develop more mutations. Apoptosis. So this kind of goes along with this over here. They're going to, so not just telomeres that will indicate when a cell should commit suicide, many different factors. And BCL2 is an anti-apoptotic protein. BCL2 actually stands for B-cell lymphoma. And we'll see this later. I believe it's follicular lymphoma and diffuse large B-cell lymphoma. And then they're going to downregulate P53. So P53 is pro-apoptosis, BCL2 is anti-apoptosis, and so both of these fall under this category. And then a bunch of things. So we talked about the Warburg effect a second ago, the idea that cancer cells are largely just going to do glycolysis. A bunch of different glycolytic enzymes and Krebs cell and electron transport things. An example being pyruvate dehydrogenase. You can just imagine that if this was turned off, you couldn't transform your pyruvate into acetyl-CoA and feed it into the Krebs cycle, so you would just have to do glycolysis. This is just an example. Many different enzymes are going to be a factor here. So a bunch of definitions to talk about. So dysplasia. Dysplasia is specifically talking about the loss of cell shape and size, so the loss of uniformity, and the idea that the nuclear to cytoplasm ratio is going to increase. And this is because they're dividing so quickly that they can't actually enlarge their cytoplasmic contents to normal values. So we see this a little bit here. Carcinoma in situ is just, more irregularity, and specifically it spans the entire epithelium, breaking through the basement membrane. So, we talked about metalloproteases, collagenases, angiogenesis to help, blood vessels sort of grow towards them so that they can have a path into the lymph and the blood, and not only, of course, just to feed them. So this is just going to be an invasive carcinoma. And then lastly, metastasis, which is where they go to a foreign area, foreign organ, either through the blood or the lymph. This is what it would look like on an actual histology. Normal, here we have a little bit of dysplasia. You can notice that we're seeing larger and more nuclei, and it's becoming slightly irregular as well. And then, it's just getting a little bit worse. And then here, this is going the entire length of the epithelium, but it's not breaking through. And so therefore, it is still in situ, or in situ. Neoplasm is just an abnormal growth of cells. Within this, we have tumor. So tumor is specifically talking about the large, swelling, gross morphological appearance. The big old bump. That's the tumor. And then a cancer is specifically a tumor that is malignant, that can invade foreign areas. So terminology is a little confusing, really important to get down. Different types of tumors. We have benign tumors, and then we have malignant tumors. So a couple differences. Benign are the good ones, malignant are the bad ones. Again, so slow and fast. These are going to be local. These can spread. This is going to be good. This is poor prognosis. Well demarcated, well differentiated. Well differentiated just means that they look like normal cells. The normal cells are differentiated. And for the malignant ones, these are not circumscribed and they are not differentiated. And, we can kind of see that here. Just to give you an idea, if you had, let's say, a mole or something, if it's symmetrical, if the borders are even, if it's just one color, if it's small, this is just a normal benign mole. But if it's malignant, then it's going to be asymmetrical, it's going to be uneven, there's going to be lots of colors, and it's going to be large. And that's a little bit what we were seeing here. So benign tumors are going to grow uniformly, and they're not as, if you have a mole, it's not necessarily something you should worry about. But a benign tumor does have the ability to transform into a malignant tumor. Two major types of cancers are carcinomas and sarcomas. Sarcomas are from the epithelium, so this is an epithelial cell lining our blood vessel, and this is our mesenchymal tissue, the connective tissue, the bones, muscles, fats, etc. The carcinoma is going to be the epithelial tissue dividing extra. And you can kind of see this here, that we're getting extra epithelial tissues growing there. And then the sarcoma being the myoepithelium, which is the mesenchymal cells, the bone cells, the muscle cells, etc. Here we can see that this is growing a little bit out of control. So mesenchymal cells are really just cartilage producing, bone producing, tendon producing, muscle producing. It could make fibroblasts, etc. There's the connective tissue, the mesoderm. That is going to make the sarcoma. So a little bit more about this. So epithelium, mesenchyme, older, younger. Most importantly is that the carcinoma goes through the lymphatic system. The sarcoma goes through the circulatory system. These are a better prognosis. These are a worse prognosis. This is less vascular, more vascular. Carcinomas you see a lot. Sarcomas you still see a lot, but I guess slightly smaller amount. So this is a lot. Just to break down a little bit more easily. So glandular, addin, squamous, not too hard. Bone, osteo, blood, heme if it's benign, angio if it's malignant, lymph, leiomyoma. So myo is muscle, so lyo is smooth. Rhabdo is skeletal. Myo is muscle. Cartilage, chondro, fat, lipo, connective tissue, fibro. So that's not too tricky. The benign is just going to be an oma, and then the malignant, if it's epithelial origin, this is going to be a carcinoma. If it's a mesenchymal, it's going to be a sarcoma. So we can just kind of throw all these together, right? If it's a bone, it's going to be an osteo. If it's a benign bone tumor, it's an osteoma. If it's a malignant bone tumor, it's going to be an osteosarcoma. So this is going to serve you guys not just for this exam, but for the rest of preclinical. Cancers show up all over the place, and it's helpful to know which ones are the bad ones, which ones are the easy ones. And this is just a good rule of thumb to get all of this down. All right, incidence. So the prostate and the breast cancers are going to be the most common for adults. And that's because these organs are very responsive to the endocrine system and various hormones, and the hormones will stimulate growth, and the growth is associated with cancer. So prostate for men, breast for women, these are the most common cancers, and therefore they're going to be also high up for the mortality. But it actually turns out that the lung is just the worst one you could have. So lung is just the worst cancer no matter what, no matter whether you're a man or a woman. Lung cancer is the highest mortality rate. But notice it is followed by the prostate and breast. So this makes it a little bit easier to memorize. Also know that for kids, leukemia, specifically ALL, acute lymphoblastic leukemia, this is the worst. This is the worst and the most common cancer. So again, not the most common leukemia, the worst common cancer, period, for kids. Cancer is the second leading cause of death. Cardiovascular, heart attacks, things like that. Strokes are the number one. A metastatic thing is a cancer that grows somewhere else, and then it travels to a new region and spreads its roots there and then grows again. And a primary one is just one that originates in that particular site. You can tell these just on a growth morphological analysis. A primary tumor is usually just going to be contained in one site, while when something metastasizes, some will go there and grow, some will go there and grow, some will go there, kind of like a weed. It'll just go and grow in many different sites. So you should be able to do, if they show this to you on the NBME, just be able to, boom, snap your fingers and you know which one is which. So we said carcinomas go through the lymph, sarcomas go through the blood. The lungs, so when you think about the lungs go to the pulmonary vein is returning to the heart, left atrium, left ventricle, it pumps immediately through the aorta. One of the first places it goes is just directly to the brain. So the brain has a direct flow from the lungs doesn't really have many other stops. It's unlikely you're going to have the cancer go in the heart. So kind of makes sense that that would be a common metastatic site. The colorectal, things in your GI system usually go through the liver for detoxification and processing. So this is also direct flow. So this one also seems kind of reasonable that a colorectal cancer would go to the liver. Prostate and breast both go to the bone. This one's a little random, but important to know. Axial, so it's going to be the spine and the skull, spine especially, and maybe the ribs. If you have a bone cancer, it's much more likely that it was a metastasis than it was a primary bone tumor. Example of a primary bone tumor might be multiple myeloma. Prostate cancer specifically, if it gets in the bone, is blastic, meaning that it builds the bone up. So you're going to have this large growth over time, and as the bone is just getting built up and up and up. Multiple myeloma is going to be an example of a lytic osteoclastic bone disease that's going to break the bone down. Many different things can cause cancer, different types of genes, different types of environmental carcinogens, and many different types of pathogens and microbes. Highly recommend this book, again, for anybody who's interested in oncology. He talks about the history of this. We had these three competing groups. It's kind of funny. One group said, we think genes cause cancer. One group says carcinogens, the environment causes cancer. And another group says it's viruses and bacteria and things like that cause cancer. And it turns out not a lot of people really thought maybe we're all right. Maybe it's a little bit of some hybrid of these three theories. Specifically, though, with the idea that it could have been a pathogen, a lot of people thought that cancer was really just caused by a virus. And so if you had cancer, it was contagious, and there was a big stigma, and you were contagious, and you had to be quarantined, and that was just awful, bad, and also wrong. But it actually turns out for Tasmanian devils, there's a type of cancer that they can bite one another, and they spread this cancer from one devil to the next devil. Couple different types of, many different types of environmental carcinogens. Aflatoxin coming from grains or nuts can cause liver cancer. This makes sense because it's metabolized by the liver when you eat food. That seems reasonable. Alkylating agents, so different chemotherapy drugs like cisplatin. This can cause leukemia and lymphoma, especially AML. We'll talk more about this later. Aromatic molecules are aromatic like the ACTG of DNA. They're going to intercalate and screw up DNA replication and transcription. Textile dyes, cigarette smokes, polyaromatic hydrocarbons. So when you're grilling and you get that nice black, crusty char that tastes delicious, that's actually very bad for you. This is going to be especially destructive for the bladder and the lungs. Arsenic, so this is going to be an herbicide. And actually, they used to, a woman's faces are fortunate, it's so funny. You would put this on your face and it would lighten your skin, and lighter skin was considered attractive back then, and it turns out this actually caused cancer, so very bad to rub arsenic on your skin. Asbestos, people have heard about asbestos causing mesothelioma. We all remember those commercials. But it's actually much more likely that asbestos causes bronchogenic carcinoma. The reason that you usually associate it with mesothelioma is because mesothelioma is like very, very... really the only thing that causes mesothelioma is asbestos. But bronchogenic carcinoma could be caused by asbestos or smoking or many other things. Cigarette smoke, we all know lung cancer. Upper GI, that also should make sense, right? It's going through your pharynx, it's going through your mouth, it's going to interact with the cells there and could cause cancer. But bladder is kind of random, but it's definitely an important one to know, is that cigarettes can cause bladder cancer. Ethanol is a similar thing. It's going to upper GIs, we're going to interact with ethanol. But then also your liver. Your liver has to work really hard to detoxify alcohol, and that could cause cancer. Radiation. So radioactive iodine is a natural byproduct of nuclear decay. And so this can mimic natural healthy iodine, get into your thyroid. T3 and T4, those hormones, use 3 and 4 iodines respectively, so it makes sense that it would get trapped there. It can cause thyroid cancer. Nitrosamines are in smoked foods. This can cause GI cancer. And then radon is just a natural, we have uranium in the ground, and this naturally decays, and this can accumulate in basement. So if you get a new house, you have to check the basement for radon. Also, if you guys have watched Chernobyl, you'll see that once they realized there was radioactive fallout from the nuclear disaster, people took iodine pills. The idea is that this would act as a competitive antagonist for the proteins in the thyroid that bind onto the iodine. So a bunch of different genes. BCR-ABL is probably the most important one. This is a fusion receptor tyrosine kinase. So BCR is an upregulated gene in hematopoietic cells. ABL is the receptor tyrosine kinase. And so we have this 922 translocation, which just causes this receptor tyrosine kinase to be way more active than it normally is. So CML, chronic myeloid leukemia. This is mostly associated with the Philadelphia chromosome, BCR-ABL. It's actually also a little bit in the adult phenotype for ALL. Not as common, but we'll see that there as well. BCL2, again, BCL stands for B-cell lymphoma. And I think of the L2, there's an L here and there's an L there. And so this is the lymphoma that's associated with BCL2. Also follicular, there's 2 L's, so that one as well. And again, this is an anti-apoptosis gene. c-KIT, cytokine receptor, this is GI cancer. c-MYC, MYC is a transcription factor. It's associated with Burkitt lymphoma. I always thought of just BC. N, neuroblastoma N, MYC is the same thing. HER2, ERB2, this one's especially important to know. This is a receptor tyrosine kinase upregulated in breast cancer, causes extra growth. JAK2 is a tyrosine kinase a little bit downstream of an RTK. This is associated specifically with chronic myeloproliferative disorders. There are 4 of them we'll talk about, so it's associated with 3 of them. The 4th one is actually just chronic myeloid, CML, but we're just, that one's not associated with JAK, so just these 3. Rett, there's a whole host of cancers under the Rett syndrome, specifically thyroid, parathyroid, and pheochromocytoma. So in other words, people who have this Rett mutation, this proto-oncogene has been converted to an oncogene, they have too much cell division, they are particularly susceptible to thyroid, parathyroid, and pheochromocytoma. This is a receptor tyrosine kinase that is now overactive. Tons of cancers have BRAF and KRAS, GTPase, serine threonine kinase, respectively. Tumor suppressors, APC negatively regulates the beta-catenin pathway. Is it the one that's associated with Wnt, the Wnt pathway? And familial adenomatous polyposis is a type of colorectal cancer that is particularly associated with APC. BRCA, most of us have heard that breast, and then CA, cancer. BRCA is associated with breast cancer. It's also associated with ovarian cancer. I have specifically this is associated with Ashkenazi Jews as well. I have a Jewish family friend whose mom just got cancer and she was BRCA positive. So this is double-strand DNA repair protein. And CDKN2, then this is just the gene name for the protein P16, which we see over here. P16 is trying to inhibit CDK4 and 6, which pairs up with cyclin D1. This phosphorylates retinoblastoma, which is normally inhibiting E2F. E2F is a transcription factor, which is promitotic. So now that we phosphorylate it, this is gone. This has now been turned off. When it's phosphorylated, E2F can now do its thing, and its thing is to push us from G1 into S. DCC is deleted in colorectal cancer. Go figure, it's colon cancer. SMAD4, so again, this is kind of a similar thing. DPC is the gene name, the protein is SMAD4. This is deleted in pancreatic cancer. Of course, pancreatic cancer. MEN1 associated with MEN2. So MEN1 is going to be another cancer syndrome. So if you have a mutation in this tumor suppressor, you are susceptible to pituitary, pancreatic, and parathyroid related cancers. P10, so P for prostate, N for endometrial cancers, and T for breast. This downregulates AKT and PI3K. Retinoblastoma, RB, this is literally the retinoblastoma protein is associated with retinoblastoma, cancer of the eye, also associated with bone cancer, which is kind of interesting. So as we saw over here, this guy's job is to inhibit E2F. P53 is the guardian of the genome. This is like the most highly cited protein in all of biology. So it's just a major tumor suppressor, has a lot to do with DNA repair. And if you have a knockout, you have Li-Fraumeni syndrome, which is where you get cancers just in tons of different places all over your body. And then the Wilms tumor protein 1 is a developmental transcription factor. This is associated with juvenile nephroblastoma. Cool. Oncogenic pathogens, EBV, Epstein-Barr virus, Hodgkin's, and Burkitt lymphoma. Hepatitis B, hepatitis C, these are associated with liver cancer. This makes sense. This virus goes ahead and infiltrates the liver. Herpes simplex virus 8 is associated with Kaposi sarcoma, largely in people who have HIV that has progressed into the AIDS phenotype. HPV, There's many different subtypes, 16 and 18. We all know this is associated with cervical cancer. We've seen the commercials. We know you're supposed to get screened. Less known is that this is actually on the rise over the past maybe 2 decades. Esophageal and oral cancers have gone up, 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 especially in men who are HPV 16 and 18 positive, and there's no polite way to say this. This is due, most people think, due to changes in sexual practices. So oral sex of a woman who has an HPV 16 and 18 just infected cells in her cervix, this can then transmit to the esophagus and lead to esophageal cancer down the road. H. pylori is associated with GI cancer, specifically mucus associated lymphoid tissue lymphoma. HTLV stands for T cell lymphoma virus. Clonorchis is associated with cholangiocarcinoma, so cancer of the bile ducts. Schistosoma is associated with bladder cancer. Grade versus stage. Grade is really just talking about the histological appearance, while stage is much more complex. Stage is integrating many different things, including the grade. So things like the clinical impression, radiology scans, size, did it spread to lymph nodes, did we do a surgical biopsy, et cetera, et cetera. What did the stain look like? This is used for survival curves. This is also used to determine what treatment plan, right? Should we do surgery? Should we do surgery and chemotherapy? Should we do radiation? Should we do them at the same time? Should we do one before the other one? What type of chemotherapy, et cetera, et cetera. So grade 1 is the good one. All of these cells look normal. Grade 3 would be the bad one. And in this case, so here we see the cells are uniform, small nuclei. Here the cells have larger nuclei, and there's a lot of variation in the size and shape. This is grade 1, and then this bottom one here, this is grade 2, and you can tell the differences. So look at all of those dark nuclei that we see. 2 different types of staging. There's the T&M staging system, and then there's the numerical staging system. So, you might hear that someone has a stage, she's got stage 4 cancer. Well, that's the numerical. T&M is a little bit less colloquial. That's the one that you'll probably hear more now in med school and as physicians. There's many different types of T and M. So T is talking about the size, N is talking about the lymph nodes that they've traveled to, and M is talking about whether it's metastasized or has not metastasized. So here notice we have so many different types of ways of categorizing T, so many different ways of categorizing the number of lymph nodes, right? Here we're saying is a carcinoma in situ. Did it get through the muscularis propria? Did it get into the subepithelium? Did it metastasize or not? Notice that this is for a very particular type of cancer. If you have a different type of cancer, there's actually so many different types of T&M staging. So T&M staging for breast cancer is going to be different than the T&M staging for colon cancer, is different than the T&M staging for, Hodgkin's lymphoma, etc. Here's another example. This is a completely different type of T&M staging. You're not responsible for knowing this, but maybe just know that there are many different ways to categorize the T&M. And yet another one. So maybe worth knowing is that the T&M is largely going to go ahead and influence the numerical stage. So here we're looking at N, there's no lymph nodes for this N0 for the T&M staging. And so this is only going to be associated with stage 1A or 1B or stage 2, but it's not in the lymph nodes. It can't be that bad as the idea. And, then if it gets into a little bit of the lymph nodes, then it might be stage 2 or it could be stage 3. Notice all of these are M-not. These are not metastasized. The second you have a metastasis, though, usually you'll say it's stage 4. So some good rules of thumb. Stage 0 is in situ. Stage 1 is it spread to the local nearby lymph nodes. It's local and small. Some people might say it's lymph nodes that are local and nearby, and some people might say it's not at all. It depends on the staging system. But stage 2 and 3 are going to be the larger and more lymph nodes. Stage 4 is specifically metastasis. And again, these are just rules of thumb, many different types of staging for different types of cancer. So it's going to be complex. But most importantly, probably is stage 0 and stage 4. All right, we do have different types of staging. We have a clinical stage. This is the one that's always done. And this is pretty good. I mean, this works. So this is, a physical exam and maybe, a surgical biopsy and some staining, some blood test. They got a CT scan or an MRI, and then the radiologist looks at the size and sees if it's in lymph nodes, and that's the clinical stage. you should always have that if somebody has a cancer. The pathological is specifically if they cut out the tumor and they actually, it's one thing to have a CT scan and say, it looks like 4 centimeters in this direction and 3.8 centimeters in the other dimension. But once you actually cut it out and get, cut out all the lymph nodes, then you have a better idea. So this might add a little bit of precision. The staging that somebody has is for when they first came in. So when you first come in, that is the stage. If you come in and I say it's a stage 2 cancer, and then for the next 6 months I give you chemotherapy, and then maybe it gets smaller, I still say it's stage 2 cancer. And then, maybe it goes away completely, and then it comes back a year later, and you have you're in remission, and then there's a failure, the cancer comes back. We still say it's stage 2 cancer. That's because the treatment options and the chances of recovery they've just found from clinical studies is that it's most highly correlated with how early your cancer is found and the stage that it was in initially. Now, there are exceptions. Sometimes you restage, but that is pretty rare. So as I mentioned earlier, the staging is going to help establish Kaplan-Meier survival curves. Obviously, stage 1 and 2 are going to be the better survival curves, and then stage 3 and 4 are going to be the lower survival curves. Also, the types of treatment. Again, everything is different. Cancers have different staging, different treatments, and et cetera. But we're just looking at cervical cancer. If it's stage 1, it's local. It hasn't gone to nearby lymph nodes, and it's small. So you can probably just hysterectomy, a larger hysterectomy, maybe. If it's stage 2 or 3, maybe you'll give a little bit of chemotherapy. Maybe you'll do radiation. Maybe you won't. If it's stage 4, maybe you'll up the dosage of the radiation, et cetera, or use a stronger dose, more cycles, higher dosage of chemotherapy, et cetera. Different stains that we can use to see what proteins are expressed. An example would be for cancer. So forget this. So this is breast cancer, and you could have breast cancer that's triple negative. You could have it be estrogen receptor positive and progesterone receptor positive, Herceptin 2 positive, this RTK that we talked about. It could be a triple positive, and this is what a normal would look like. And this will just tell us what types of targets we have for this particular type of breast cancer. So that's very useful. So a couple stains to know. If you see the granin or synapto, well, at the end of a neuron or a neuroendocrine cell, you have granules where you'll release your neurotransmitters or your endocrine hormones. And then a synapse is the end of a neuron. So both of these should make sense that these are associated with neuroendocrine cells. Small cell carcinoma of the lung is highly, highly neuroendocrine based. Keratin, we know, is epithelial cells. M for muscle. GFAP, so you're going to see this a lot, especially in the neuro section. G is for glial, and then protein. So these are going to be all of the accessory supporting cells that nurse the neurons. Things like astrocytes and other glial cells, but there can be a few others as well. You probably, if you get a brain tumor that's primary, it's unlikely to be a neuron, because remember, the neurons don't really divide that much, but the accessory glial cells might divide a lot. Neurofilament is a neurons, go figure. Again, this is probably going to be rare, or there might be other circumstances that would explain why the neuron that's usually in a quiescent state is dividing. PSA, prostate-specific antigen, is going to be associated with prostate cancer. This one is really important. Again, not only because the incidence of prostate cancer in men is number 1 and the mortality is number 2, but because it's just a very specific antigen that is produced in high abundance and it's easy to detect. So prostate cancer is very preventable just if you get your PSA checked. So S100 is going to be in neural crest cells. So this is going to be the ectoderm that is in the peripheral nervous system. So your skin and your peripheral nerves. So this would be a melanoma or Schwann cells, we can remember, are specifically in, melanoma is obviously skin, and then the Schwann cell wraps the neurons in the peripheral nervous system. Oligodendrocytes wrap the neurons in the central nervous system. So both of these are peripheral and therefore neural crest. Langerhans cells are the dendritic cells that we see in the skin. TRAP is specifically going to be hairy cell leukemia, which we'll talk about. And then Vimentin, ME for mesenchymal tissue, which we already talked about, which is associated with sarcomas. Sometimes you see these concentric circles of dystrophic, so just like kind of like necrotic tissue calcification. We can get rid of this and get rid of this. So P for papillary carcinoma of the thyroid, S for somatostatinoma, meningioma, mesothelioma, ovarian adenocarcinoma, and then milk, specifically to say that this is a prolactinoma and the anterior pituitary. And these are really big giveaways on histological analysis. A couple of tumor markers. So these are usually very sensitive for a particular cancer, but not specific. That is to say that many different things might produce something like ALP or alpha fetoprotein or HCG. So we don't usually use it as a primary way for the diagnosis. But we can buttress a diagnosis. For the most part, though, we're going to use it to monitor how well you're responding to therapy and to see if the cancer is coming back or how well you're doing. Alkaline phosphatase is associated with phagocytes. So a lytic bone cancer, osteoclasts, remember, have a phagocytic hematopoietic precursor lineage. Liver cancers have Kupffer cells, which are just the name of macrophages in the liver. So both of these cancers are going to be associated with ALP. Alpha fetoprotein, this is a fetal version of albumin. Well, the liver makes albumin, so it kind of makes sense that this particular, in a cancer of the liver, somehow the fetal albumin gene could somehow get turned back on. It's also going to be associated with yolk sac and germ cell tumors, which also would make sense that this is associated with fetal things. Not really related to cancers, but might as well say it. Neural tube defects and Down syndrome are highly associated with alpha fetoprotein. HCG is, this is what the pregnancy tests detect. This is the equivalent to LH. It's secreted by the placenta. It keeps the corpus luteum going, which is the remnant of the follicle. And it's associated with choriocarcinoma. The chorion is really part of the placental tissue, so that one should make sense. Also kind of makes sense that it'd be associated with a lot of germ cell related tumors, so testicular cancer and germ cell tumors. Thyroid produces calcitonin. That one should check out. CEA is carcinoembryonic antigen. So remember that selectins are something that the epithelial will express, which can capture these leukocytes, these neutrophils, can slow them down. They have the rolling, and then they can extravasate through the endothelium and into the tissue where the infection is. And so this particular CEA is largely associated with the selectins in the GI. So it's associated, therefore, with colorectal cancer, which kind of checks out. And one of the effects of this is that it will impair or block neutrophil extravasation and the inflammatory response. It could also allow a cancer particularly to metastasize into or out of. And so we kind of see this here. This is the normal picture, is that they'll bind and then they'll move through. And here, they'll bind, they'll block the neutrophil from binding, and then they will be able to extravasate through. Chromogranin, so we just saw this. Granin, remember, granules for neuroendocrine cells. And this could be many different types of cancer, of the thyroid, the small cell carcinoma, etc. LDH, lactate dehydrogenase, this one's kind of random, germ cells or ovarian tumors. And then PCA we talked about is specific for the prostate. CEA 19-9 is pancreatic, 125 ovarian, and then 15-3 is breast. I wish I had a fun mnemonic for that, but I don't. A bunch of paraneoplastic syndrome. So paraneoplastic syndrome is really just something that a cancer causes that is seemingly distant and unrelated features. So it's just kind of a, for lack of a better way to put it, it's a random thing that the cancer causes that is just a very noteworthy phenotype, a clinical presentation that is just seemingly bizarre. Like if you had a brain cancer, you have a headache. That makes sense because you got a big tumor in your head. But that wouldn't be a paraneoplastic syndrome. That's pretty direct. But something like a GI cancer causing, cancer of the stomach causing acanthosis nigricans, something associated with diabetes and obesity of the axilla, and the folds of the neck, and the sign of lesser trelat, seborrheic keratoses in the back. These are kind of random. So this is random, very, very random. And so that's how I always think of paraneoplastic syndromes. So if someone is hypercalcemic, parathyroid hormone-related protein, many different types of squamous cell carcinomas will produce this, and this will cause calcium levels to go up. Or it could be lymphoma. Lymphoma is, in the lymph, we have a lot of macrophages, and macrophages possess the enzyme 1-alpha hydroxylase, which is necessary to produce a functional vitamin D, which will cause more calcium to be absorbed in the small intestine. Cushing's disease, so too much cortisol. Hyponatremia, because we have too much blood volume or too low sodium count. And then Lambert-Eaton myasthenia. So all of these are going to be small cell lung cancer. So ACTH for Cushing, ADH, antidiuretic hormone, also known as vasopressin, to cause the hyponatremia, and then an antibody for calcium receptors to cause the LEMS. So small cell lung cancer, and I bolded this one because it's important, it comes up a lot, causes a bunch of random phenotypes, and again, that's why this is perineoplastic. So LEMS is very related to myasthenia gravis. So we're talking about a thymoma here. An antibody against the postsynaptic acetylcholine receptors. So the reason these are related, remember that for muscular contraction on the presynaptic side, the action potential moves down, and this causes a depolarization, which causes calcium to flood in, which causes the vesicles to fuse with the synapse, releasing the neurotransmitters. And the neurotransmitter acetylcholine binds to the postsynaptic receptor, which causes a muscular contraction. So whether or not I have an antibody for the calcium receptors or I have an antibody for the postsynaptic acetylcholine receptors, I have a similar phenotype, similar clinical presentation of abnormal muscular contraction. So that's the first thing of the thymoma, the first perineoplastic syndrome. Second would be red blood cell aplasia. I don't actually know what causes that, so I don't have a good answer there. And then finally, because you don't have T cell development, you have a hard time stimulating your B cells, and you have hypogammaglobulinemia, so you have a deficiency of antibodies. Polycythemia is due to excess or secondary polycythemia. We will see polycythemia vera, which is a primary, which is coming later with the myeloproliferative disorders. This is due to excess EPO production. Well, it makes sense that a kidney cancer might do this because the kidneys typically produce EPO. Kind of randomly is that pheochromocytoma, a cancer of the adrenal medulla, might also cause excess EPO, which could cause polycythemia. Tumor lysis syndrome. So yes, cancer cells are dividing a lot, but they're also dying a lot. And when they die, they spill a lot of their guts into the blood. Things like potassium, things like phosphate, a bunch of nucleotides. So the nucleotides, there's so much, remember we see this high nuclear to cytoplasmic ratio that we don't see in normally cells. So there's so much DNA and not a lot of stuff in the cytoplasm. So much DNA, so when the cell dies, you lose a lot of ACs, Ts, and Gs, which means you get a lot of phosphates, which also means you're going to have a lot of your nucleotides broken down into uric acid. So the phosphate specifically will also bind into the blood to calcium. So the blood calcium levels go down. Nucleotides are broken down into uric acid. So the phosphate, calcium crystals, or I guess more just the phosphate here is causing the crystals with uric acid, can cause kidney injury. Low calcium levels can cause seizures and tetany. Changes in your ECG. High potassium levels can cause arrhythmias and muscular weakness. Okay, cool. Hope that was helpful. Part 2 coming up. All right, let's talk about hematopoietic proliferative disorders with an emphasis on chronic myeloproliferative disorders and plasma cell dyscrasias. So first, we're just going to go over general overview of hematopoietic lineage. Talk about the hematopoietic cancer family tree, looking at leukemias versus lymphomas. Then we'll dive a little bit more into detail for the chronic myeloproliferative disorders and the plasma cell dyscrasias. So looking at hematopoietic stem cells, this branches off into two categories, myeloid and lymphoid progenitors. The lymphoid are, for our purposes, just going to give rise to the T and B cell lineage. The myeloid will give rise to the basophil, neutrophil, and eosinophil, mostly what we're interested in. So these are also sometimes known as granulocytes. So we're a little bit less interested than most of the other things here. So a little summary of this is just the myeloid, myeloblast. So blast just means immature. And again, this is eosinophils, basophils, and neutrophils. Neutrophils, far and away, though, the most predominant form here. And then B cells and T cells, ignoring natural killer cells. So we'll circle back to that at the end. But leukemias are really just a cancer, proliferative disorder of the bone marrow, while lymphomas are a proliferative disorder of the lymph nodes. So you can really break down hematopoietic proliferative disorders into 4 different categories. Leukemias, So in this case, these are in the blood and in the bone marrow. B cell, or it's going to be more than T cells. Specifically, it's lymphoid, but it could also be myeloid. Malignant because it can metastasize and spread. Lymphomas also would be categorized as malignant. Now, these cannot be myeloid. These are only lymphoid, and like we said earlier, they're in the lymph nodes. And then the plasma cell dyscrasias are going to be in the bone marrow, and as plasma cells are really just activated B cells, they are characterized by lots and lots of antibodies, lots of immunoglobulins. Lastly, we have the chronic myeloproliferative disorder. Notice that this is the only non-malignant proliferative disorder. So this will be mature myeloid cells only. So we have a combination, lymphoid only, B cells only, and then mature myeloid only. Basically, neutrophils. Again, neutrophils are by far the most common mature myeloid cell. So now breaking down into all of the categories and subcategories, ALL, AML, CML, CLL. So this is, acute and chronic and lymphoblastic and myeloid, and then hairy cell leukemia. The lymphomas can be categorized under non-Hodgkin's or Hodgkin's. The non-Hodgkin's has several categories. We can break it into B cells, B cell non-Hodgkin lymphoma, Burkitt, diffuse large follicular mantle marginal primary CNS. And then T cells is less common, but we have adult T cells and mycosis fungoides, which can progress into a type of leukemia known as Sézary syndrome. There's a couple of subtypes of Hodgkin's, but those are less important. Plasma cell dyscrasias, there are 3, multiple myeloma, MM, Waldenström macroglobulinemia, and monoclonal gammopathy of undetermined significance. The chronic myeloproliferative disorders, we have polycythemia vera, myelofibrosis, essential thrombocytopenia, and CML. The reason CML is underlined is because it technically can be categorized as leukemia and also as a chronic myeloproliferative disorder. This is probably the categorization that you would be more familiar with. So looking at leukemia etymologies, hopefully it's still on. All right, so looking at leukemias, ALL. So acute really just means that these are immature, so they're going to be called blasts. Acute leukemias arise really rapidly. The second L is for not leukocytic, actually it's for lymphocytic. Lymphocytic, so this can be a T or a B cell. Again, we said that usually it's a B for both leukemias and lymphomas. And then lastly, leukemia. So all of these 4 leukemias are going to have the last L represent leukemia. Leuc just means white blood cell. Again, this can be myeloid or lymphocytic. And then emia just means in the blood. So again, acute, rapidly rising blast. Now we have M for myeloid. So this will be myelo, and specifically blast because it's the acute version. And then again, of course, leukemia, they all have this. Chronic is going to be a mature, more differentiated cell. It's going to be slower forming. And in this case, because it's a chronic, we said that the chronic is going to be the neutrophils as opposed to earlier where it was the myeloblast. And again, still leukemia. And lastly, C for chronic, mature, slow forming. And again, L for not leukocytic, but lymphoblastic. And then the lymphocyte could be T or B cell, usually B, and leukemia. So the big picture here, this is really just on the spectrum of age. I like to think of so this is going to be young, and this is going to be old. So I've actually gotten a little bit of mixed data on this. I've looked into this. So what I'm very confident in is that ALL, so this is, for the most part, this is, you can think of the M's for medial. M for medial or M for middle. I guess you can think of the L's for lateral, but these two go in the middle. And then if I'm categorizing between these two, A becomes before L. So that's how you can remember that this is the first one, this is the second one, this is the third one, and this is the fourth one. So what I'm very confident in is that the ALL is the kids and the CLL is the eldest. I've seen some data to support the idea that AML is in their 50s and 60s, and maybe CML is also in their 50s and 60s, but maybe a slightly older age. So it's one way you can think about it. Alternatively, you could just think of these are about the same age, 50s and 60s. So kids, 50s and 60s, and then CLL is going to be 60, 70, and older. Cell type, we already went through this: immature lymphocyte, immature myeloid, mature myeloid, and mature lymphocyte. Specifically look for our rods. I think of A for our rods here, and then M for myeloperoxidase. So our rods are really just precipitated myeloperoxidase. So these two things should go together. Our rods are really just myeloperoxidase that is precipitated. The stain here would be TDT plus. So this is going to help immature lymphoblasts generate diversity through recombination, so it makes sense that they have TDT. CD10 is also going to be a marker for immature lymphoblast, specifically of the B cell origin. In the translocations, we have 1221 and 922. 922 is also the Philadelphia chromosome, so we do see that here in CML. This is mainly where you're going to see 922, but you see a little bit of 922 over here. 922 for ALL will be worse prognosis, often for adults, and then the 1221 is going to be the slightly better prognosis often for kids. So I think of this as a mirror. So 1221, this is a mirror, and a mirror for minors. Excuse me. Mirror for minors. 1517, this is not all AMLs, but some AMLs are acute promyeloid leukemias, and they will have this particular chromosome, which we'll talk more about later. Lastly, the smudge cells are going to be shown on the CLL for. But again, these are the main four. We also have hairy. So hairy is going to be mature B cells. Specifically for the histology, you look for the hair-like projections, and for the staining, you look for TRAP. Lymphomas. So non-Hodgkin's is the worst prognosis. Hodgkin's is the better prognosis. Some people might say if you want to have one of the lymphomas, better to have the Hodgkin's. That is the good cancer. If you have a swollen lymph node and it's painful, it's probably an infection. If it's not painful, it might be a cancer. Hodgkin's also is a bimodal distribution. So really young people, really old people, often not middle-aged people. Most important here is the young. If anybody shows up on your NBME with they're young and they have a swollen lymph node, it's more likely to be a Hodgkin's lymphoma. Non-Hodgkin's is typically going to be older people. CD15 and CD30, so I think a 15 times 2 is 30. And where does the 2 come in? Because these Reed-Sternberg cells have these giant cells which are multinucleate, multi-lobed here. So I think of 1, 2 times 15 is 30, and just all of that kind of comes together. Now, the Reed-Sternberg cells look very much like, you squint your eyes, kind of looks like an owl. So the owl eye Reed-Sternberg cell is pretty easy to notice, and that the histology. Cool. Leukemias, you can think of as lemonade. So leukemia is a cancer of the blood, so it's in the fluid. Lemonade is a fluid. However, at the same time, we might have some seeds in a lemonade. And you could take these seeds and you could plant them and you could grow a lemon. So lemon would be the lymphoma component. And you know what you can do? You can take those lemons and you can squeeze them out and you can make some lemonade. The point here is that leukemias can become lymphomas, and lymphomas can also become leukemias. Taking a look at these second two categories, plasma cell dyscrasias and chronic myeloproliferative disorders. Let's go ahead and start with this one. So plasma cell dyscrasias, for the most part, plasma cells are just making tons of antibodies, so we should look for lots and lots and lots of antibodies. Specifically, this will be an M spike on a gel electrophoresis. Let's go ahead and take a look at this now. So this is what a normal gel electrophoresis will look like for plasma cell proteins. Albumin is the most abundant protein in the plasma, so we have this large spike here. This alpha and that alpha goes with these particular proteins, and this goes with this protein, and these go with these proteins. Note this is IgA, IgM, and IgG. Most importantly, we're going to be looking at IgG and IgM. But if you have too much of some antibody, it's most likely going to be in this gamma category. And so this would be a normal in green, and then in red, you get this large spike around the gamma section. This is called the M spike, and it's associated with any of these plasma cell dyscrasias. Most important is going to be the multiple myeloma. And people say that you look for the Crab syndrome. So what are the Crab syndromes? So remember that the main point of these are that we are overproducing antibodies because we have sort of a B cell cancer. So this excessive monoclonal IgG production. So this first one, if I have excess IgG production from a B cell cancer, I'm going to have decreased production of normal IgG. And if I have decreased IgG normally, I'm going to have an infection. So C for chronic infection. At the same time, excess IgG production, and these are the irregular, non-functional IgGs, but nevertheless, there's still way too many proteins in the blood, and these proteins are going to be damaging to our kidneys and our bladders, and so we have a lot of renal failure associated with this. This is going to cause the clinical presentation of thirst, polyuria, people peeing a lot, and you'll find Benz-Jones, which are just the light chains of the IgG overproduction in the urine. Also note that so BG, the Benz-Jones proteins, is something you should look for. And Rouleau, these kind of look like a bunch of poker chips stacked up. So antibodies are going to agglutinate and bind red blood cells together. And too much antibodies in the blood is going to bind all of these red blood cells together in this very specific pattern. So this is what's going on here. If I have B cells overdividing in the bone marrow, I'm crowding the bone marrow, which means I cannot make my red blood cells and I cannot make my platelets. So you will have fatigue and pallor also as clinical symptoms. And increased bone turnover. If I have cells, we saw earlier, if cells are dividing too much, those cells are also going to die a lot. And osteoclast activity might be up, and this will cause lytic bone lesions. And this can cause, this is going to be more often in the axial and the appendicular, but this will cause back and rib pain. And the destruction of all of these cells is going to cause hypercalcemia, spilling all this calcium into the blood. Hypercalcemia is associated with nausea, constipation, and a bad appetite. So monoclonal gammopathy of undetermined significance, this is really just a pre-multiple myeloma. And it's an overproduction of any IgG type. So typically this might lead to this. A Waldenström macroglobulinemia is specifically an overproduction of IgM. Recall that IgM has these 5 antibodies really rolled up into one. So it's going to be particularly good at agglutinating and bringing the red blood cells together. This is going to increase the viscosity of the blood, causing a hyperviscosity syndrome. So we can think about, again, IgG, because it has all these 5, is particularly sticky. Presentations for hyperviscosity or headaches and blurry vision. All right. Lastly, myeloproliferative disorders. So again, we have 4: polycythemia vera, myelofibrosis, essential thrombocytopenia, and CML. But remember that CML is only technically one of these. It's probably better to think of this as a leukemia. So polycythemia vera, also known as primary polycythemia, we have too many red blood cells. All of these, except for CML, will be associated with JAK2. So this is a JAK2 mutation, as opposed to secondary polycythemia, where I have too many red blood cells because I have a pheochromocytoma or some sort of kidney tumor, which is overproducing EPO, stimulating excess red blood cell production. Presentation here is aquagenic pruritus, which is where you get particularly itchy after a hot shower. And hand-foot syndrome, also known as hand-foot erythromelalgia, which is a burning pain and red-blue discoloration, specifically due to vaso-occlusion. So here's a picture here. Myelofibrosis, so we've increased fibroblast activity in the bone marrow. And if my fibroblasts are dividing too much, then it crowds out the bone marrow. And if I do a bone marrow biopsy or extraction, it's going to be a dry tap, meaning that you can't really pull cells out of the bone marrow like you normally would. The bone marrow is crowded out. You can't produce anything that you need. The organs that step up to the plate to try to produce hematopoietic stem cells, so it should be the bone marrow only that's making hematopoietic stem cells, but your liver and your spleen will actually try to moonlight as hematopoiesis organs. Also the skin a little bit. So you might get enlarged liver, spleen, and also this blueberry skin, which is the hematopoiesis occurring outside of the normal bone marrow. And you get these red blood cells that are teardrop shaped. Essential thrombocytopenias, we have too many platelets. These platelets might be large and deformed, so you could see that in histology. CML, we again said, is a leukemia, too many granulocytes. Now, CML, chronic, means mature, M means myeloid, so the myeloid, leukocytes, and again, this is basophils, eosinophils, but mostly neutrophils. These are by far the most common. This is associated with the Philadelphia chromosome. And you can remember that for Philadelphia chromosome together is 22 letters. and I remember that as the second chromosome for this translocation. So just to kind of summarize all of this up, if we look at ALL, A for acute. Acute means we're looking at the blast. If I'm looking at the blasts and it's L, it must be a lymphoblast. So I'm looking at the lymphoblast here. Again, I have A, so I'm looking at the blast, but now it's M, so I must be looking at the myeloblast. Then we have CML, which means I'm looking at the differentiated one. So at the differentiated ones here, and we said specifically it's probably going to be the neutrophil. So look for a high neutrophil count. CLL, so C again for differentiated and L for lymphoblastic. Specifically, it's going to be the B and the T's, ignore the natural killer cells. We said that B is more common than T. Hairy is specifically only going to be B. We have lymphomas. Lymphomas are typically going to be B or C, but often with B. Plasma cell dyscrasias are going to be B, which is matured and differentiated, activated into a plasma cell. And the myeloproliferative disorders, which are the mature granulocytes, and the mature red blood cells and the mature platelets. And we said that this was polycythemia vera and essential thrombocytopenia and myelofibrosis as well, not shown in this particular picture. Great, on to leukemias. All right, let's talk about leukemias. We're going to do a basic intro plus signs and symptoms, then take a look at the leukemia family tree, how to distinguish between the 4 major types of leukemia, then we're going to dive into each one of them, and finally we will look at hairy cell leukemias. So again, leukemias are cells in the blood and the bone marrow. Typically they are of lymphoid origin, where B is greater than T, but they can also be of myeloid origin. So a couple signs and symptoms of leukemia, like all cancers, cachexia, weight loss is a symptom due to TNF alpha production, which causes catabolism of fat and muscle cells. Swollen lymph nodes, these should be painless. Again, you might see this in lymphoma. That would make a little bit more sense. Typically, this will be indicative of the fact that a leukemia has infiltrated a lymph node. And most of the symptoms, though, are due to inappropriate hematopoiesis. So if your bone marrows are not producing the red blood cells, the platelets, the leukocytes that you need, your liver and your spleen and your skin will take over. This will cause hepatosplenomegaly, but it will also cause what's sort of blueberry-looking skin. And these are all extramedullary hematopoiesis, other organs trying to take over the job of hematopoiesis from your bone marrow. No red blood cells will cause fatigue and weakness. So much cell proliferation will also be associated with a lot of cell death. This causes a lot of cell turnover, which is associated with bone pain. And similarly, if we have a lot of cell turnover in the bone, there's a lot of calcium, a lot of hydroxyapatite, and then that is going to be spilled into the plasma, which might cause hypercalcemia. If I don't have appropriate hematopoiesis, I don't have neutrophils, and and this might lead to infections. And lastly, without the thrombocytes, I might develop nosebleeds, easy bruising, bleeding, and perhaps a petechia. Remember that platelets are associated with more superficial bleeding as opposed to deeper joint bleeding being associated with coagulation cascade. And so let's take a look at these 5 major types. So again, this is all in the bone marrow, and it's either going to be blasts if it's acute, or if it is chronic, it'll be of the mature form. So when you're looking at any of these names, the first letter is whether it's acute or chronic. So I'm looking at acute, chronic, acute, chronic. Acute means immature, chronic means mature. And then the second letter, L for lymphoid or M for myeloid, lymphoid and myeloid. So these would be ALL would be an immature lymphocyte, so B or T cell that's immature. On the other end of the spectrum, CML would be chronic, meaning a mature, differentiated cell, not a blast, and M being of the myeloid origin. So this could be an eosinophil, basophil, or neutrophil, probably a neutrophil because that's the most common one. So I like looking at it in this simple spectrum. You can think of the M's as being associated with medial. These are in the middle. And then other than that, it's just alphabetical. So A would be on the left end of the spectrum and C would be on the right end of the spectrum. And you can kind of ignore that. So Again, M is going to be in the middle, and these are associated with middle ages. And then alphabetical A is associated with kids. Again, this is the young, this is the old, and then the C is going to be associated with the elderly. That's actually really helpful. Like, if you don't know anything else, that can be very informative when you're trying to decide what the answer is in a vignette. And we already talked about the etymology, right? The ALL, A, acute, immature, L, lymphoblastic. This is an immature lymphocyte. Immature myeloid, mature lymphocyte. For the histology, A for hour rod, so think A for hour, and similarly you can think of M for myeloperoxidase. What's the link between these two? Well, an hour rod is simply just a precipitation of insoluble myeloperoxidase enzymes. We have a smudge cell for the CLL. And then for the stains, the proteins that we see, TDT, terminal deoxytransferase, is going to be helping promote genetic diversity for B cells and T cells. And if it is a B cell, remember the the lymphocytes could also be a T origin, CD10 is going to be present. Translocations 1221 is going to be the good prognosis for minors. 922 is the Philadelphia chromosome. This is going to be associated with a worse prognosis for older individuals with ALL. 1517 is sometimes present only if it's APML, also known as APL, acute promyelocytic leukemia. And 922 is going to be the main instance where we see the Philadelphia chromosome on CML. We also have hairy cell, which is going to be a mature B cell, hair-like histology, and then a trap stain. So quick note for any sort of lymphocytic markers. So anytime we're dealing with a lymphocyte, the smaller numbers, 1 through 8, are T cell, and the larger numbers, 10 through 23, are going to be B cell associated. But on top of that, notice that here we're in the blast region, anything to the left of this. And for the blast, I have TDT and TDT. And again, that's because TDT randomly adds nucleotides to promote more diversity for antibodies and T cell receptors, so via recombination. And then the CD10 is a marker specifically for immature B cells. So that can tell us if it's lymphocytic versus myeloid, and then if it's a mature lymphocyte versus an immature lymphocyte, and then specifically if it's an immature B lymphocyte versus an immature T lymphocyte. All right, let's start with ALL. So ALL is the first in our spectrum. We can think of it as alphabetical. This has to deal with kids. Now, this is an average. Can an adult get ALL? Yes, but more often than not, this will be a kid, and it's just rare. The other leukemias typically do not affect kids. So if it's a kid, it's pretty safe to say it's a Hodgkin's lymphoma or an ALL, acute lymphoblastic leukemia. So as we said, immature lymphocytes. This is the most common cancer. We talked about this in the first section, epidemiology. So not just the most common leukemia, the most common cancer for kids. It is TDT positive to promote recombination and diversity, and CD10 if it's a B cell. 1221, again, think of this as a mirror, right? 12, the mirror would be 21, right? You think of like RS in organic chemistry. That is a mirror, and it is for minors because ALL is for minors, and it's also a minor prognosis. On the other hand, 922 is for is the Philadelphia chromosome. This would be adults with ALL, which is less common, and it would be a worse prognosis. Usually it's B cells. If it is a T cell, it'll be a large mediastinal mass. Well, how do we remember that? Remember the thymus is in the mediastinum. So if I have a T cell leukemia, it would make sense that my thymus is going to be quite enlarged, and so I'm going to have an engorged mediastinum. Sanctuary sites, so where chemotherapy might not infiltrate, might be less effective, or metastasis might occur, is in the testes for boys. And so then when this is followed up by radiation, this might lead to infertility, also in the brain and the central nervous system. AML, again, the M's are for middle-aged, and so this might be like 50 or 60 on average. And again, that is an average. You can have any different age, so just keep that in mind. Immature myeloid, we get that from the name. Myeloperoxidase, remember that to generate bleach, HOCl radical from hydrogen peroxide, we use MPO, myeloperoxidase. This is in neutrophils. This is something we talk about in immunology, so it should make sense that this shows up here. And I think of this M as standing for myeloperoxidase, and this M as standing for hour rods. What's an hour rod? It's just a bunch of MPOs that are precipitated together. This is very high yield to be able to recognize this on a histological slide. If the hour rods somehow get into contact with the rest of the plasma, this can lead to disseminated intravascular coagulation, DIC, where we might have lots of coagulation in one region, which uses up all of our clotting factors, and so we have no clotting in the next region. 1517 is a translocation that sometimes occurs, probably a minority of the time, but sometimes you'll see it. And specifically, it's an all-trans-retinoic acid receptor that is defective. This is called acute promyelocytic. So sometimes APL, sometimes APML. And well, it's the all-trans-retinoic acid receptor that's defective. So this particular cancer might respond to all-trans-retinoic acid, which binds to this upregulated receptor. This is really just vitamin A. Note that this does not kill the APML or APL. It merely causes them to differentiate, right? Acute is blast, they're immature. M is myeloid. So this causes them to mature to differentiated neutrophils, which can somewhat attenuate the cancer presentation. AML might be caused by other types of cancers. So myelodysplastic disorders, where we have excessive proliferation of myeloid cells in the bone marrow, often it's as a result of chemotherapy and radiation. So I've bolded this because this is really important. This can cause the myeloplastic disorder, which then might cause AML to develop. CML is chronic myeloid leukemia. This can technically progress to AML. So we'll see this in a hot second. Right here. So CML, remember that this is technically a myeloproliferative disorder, not to be confused with a myelodysplastic disorder, which is caused by radiation or previous chemotherapy. Again, M for middle age. So this is middle-aged individuals, 50s, 60s on average. And it is mature myeloid, as we get from the name. And myeloid is, again, eosinophils, basophils, and neutrophils, mostly neutrophils. 922, Philadelphia chromosome, count them out. That's 22 letters and is associated with the 22 over here. That's how I remember it. BCR-ABL. So BCR is just a gene that's upregulated in leukocytes. ABL is a receptor tyrosine kinase that is pro-mitosis, pro-division. And this is why we might have this become cancerous. Imatinib, which is a really great drug that came out in the early 2000s, called Gleevec. It's a really effective chemotherapy drug. I think the mortality rate, like a 5-year survival, was 22%, before 2004 or something, before Gleevec, and then after it was like 90+% survival. And it's just a pill. I mean, this is an amazing drug. Note, as we just saw on the last slide, that CML can progress to AML. Now, how do we differentiate this? So this would be AML. So maybe we have 1,000 cells here. Let's pretend that there's 1,000. We count them all up, there's 1,000. Now, these neutrophils that I'm looking at here, and again, we can see this characteristic nucleus for these neutrophils. Maybe I count these and I see that there's 100. So that means 10% of my cell might be, the myeloid origin or blast or something. But as the disease progresses, we might have something that's called a blast crisis, where now the bone marrow has more than 20% cells that are blast. And notice here we can see that there's certainly a lot more. So maybe it's still 1,000 cells total, but now I count them up, maybe now there's 300. So now this is 30%. It's an arbitrary cutoff, but if we're over 20% of cells in the blood smear are blast, we now call that AML rather than CML. CLL is the eldest. Remember our spectrum, we had ALL, then we had the M's for medial, and then we have CLL as for the elderly people. So these are on average old. They could be younger, but they're probably going to be old. Mature lymphocytes from the name, smudge cells is the histology we look at, and it progresses really slowly. So this, in combination with the fact that it's elderly individuals, means that, if you've got someone in their 80s who has a cancer that takes 10 years to develop, you might not go for really aggressive chemotherapy. So we're going to give them a very mild treatment. If anything, sometimes we don't treat them at all. Sometimes a Richter transformation occurs, which is where the CLL will sort of morph into an aggressive, diffuse large B-cell lymphoma. Lastly, hairy cell leukemia. So hairy cell is going to be in adult males. I think of adult males as hairy, having hairy legs. They're going to be mature B cells. And the histology, filamentous hair-like projections. We can kind of see this here. We can see these sticking out a little bit. A dry tap, just like we saw in myelofibrosis, the chronic myeloproliferative disorder. So if I don't have hematopoiesis going on in my bone marrow, I'm going to find other places to do it. We're going to look at the spleen. We're going to look at the liver. So hepatosplenomegaly is going to be common. And maybe the blueberry skin is our skin is now trying to produce white blood cells and red blood cells. So extramedullary hematopoiesis, and then pancytopenia, because even though we have extramedullary hematopoiesis, it doesn't work nearly as effective as the bone marrow. So I'm going to have a deficiency in red blood cells. I'm going to have a deficiency in platelets. And I'm going to have a deficiency in white blood cells. And you can then imagine that that's going to cause things like fatigue and chronic infections and easy bruising, things like that. TRAP, tartrate-resistant acid phosphatase, is a common stain, is a commonly upregulated protein that we see in these particular cells. And hairy leukemias are associated with the BRAF mutation. All right, let's talk about lymphoma. We're going to do a basic intro, talking about signs and symptoms. Then we will jump into the family tree of lymphomas, followed by Hodgkin's, and then a breakdown of all of the non-Hodgkin's types, including the B and T cell subtypes. And then we'll just do an overview of translocations in general for lymphomas and leukemias, plus look at major histologies that I think y'all should be able to recognize. All right, so we talked about leukemias, we talked about plasma cell dyscrasias, chronic myeloproliferative disorders, last but not least. So specifically lymph nodes, as you might have guessed, and it is lymphoid, not myeloid. B is greater than T. Painless, swollen lymph nodes. If they are painful, it usually is indicative of an infection. If it's painless, it's more likely to be a cancer. Night sweats are also going to be a common sign. And this is on top of things like cachexia that we might have seen earlier in weight loss. So people have lymph nodes, and that's where the cancer is going to be. And we're going to see some of these terms like follicle, medullary, things like the cortex or the B cells and paracortex for the T cells. We talk a lot about this in the immunology section, but we're going to see things like marginal lymphomas and follicular lymphomas, et cetera. So that might be mildly helpful to review. All right, so this breakdown is into two categories: non-Hodgkin's, Hodgkin's, which has these subtypes and these subtypes. A couple more subtypes of Hodgkin's that we'll see, but much less important. So like we said, breakdown looks like this. And the two overarching categories are the non-Hodgkin's or Hodgkin's, which we've talked about previously in the overview. The worst prognosis is for non-Hodgkin's. So if you were going to have a better Hodgkin's lymphoma, it would be the Hodgkin's rather than the non-Hodgkin's. Bimodal distribution, so very young, very old, but I would just know that young is the more important thing. If young people have a cancer, it is probably going to be Hodgkin's or ALL. 15 times 2 is 30. Where does the 2 come in? Because we have these 2 eyes for these these bilobed, binucleate giant cells. These are called Reed-Sternberg cells. These are very, very, very telling, and they look very much like owl's eyes, in my opinion. So the Hodgkin's subtypes, nodular sclerosis is the most common. The lymphocyte-rich, well, this is the best prognosis. Mixed cellularity is immunodeficient patients. And there's an eosinophilia that you don't see in the next one, which is very related. The lymphocyte depleted, also with immunodeficient patients. Again, though, for all of these, the major thing to look at is just, do we have these owl eye-looking Hodgkin's Reed-Sternberg cells? So jumping into the non-Hodgkin's subtypes, T cells, again, B is greater than T. In other words, B lymphocyte leukemias are more common, and the B lymphocyte lymphomas are also more common. So we have 2 types: adult T cell, so human T cell lymphoma virus. So often people who use things like heroin, IV drug use, are going to be common for this type of virus. And this is causes lytic bone lesions, like we saw in multiple myeloma and prostate metastasized bone cancers. This might cause a breakdown, which can cause hypercalcemia specifically. And actually, I apologize. I think prostate is osteoblastic, so I take that back. I believe this is multiple myeloma type lytic bone lesion that we might see. Mycosis fungoides is the other type. This is just going to be most noteworthy for large cutaneous lesions, so here, and here. And it might progress to something called Sézary syndrome, which is a T-cell leukemia. All right, a lot more here, a lot more meat, a lot more stuff to pick apart. B-cell non-Hodgkin's lymphoma. So 6 major types we need to worry about. BMF, bad motherfucker. So this is 14 letters. You count them up, this is 14 letters. You know what else is 14 letters? immunoglobulin. And that is because all three of these have the immunoglobulin chromosome 14 translocation associated with it. And as you can imagine, for a B cell, the immunoglobulin heavy chain is particularly upregulated. So that is what this is showing. So 14 always is showing we're really interested in that highly upregulated immunoglobulin promoter. So that's one way to keep all of these in mind. So let's go through Burkitt first. So the histology is that sometimes it's called a starry sky histology. So I thought B for beautiful. So macrophages look like these little white stars over here. And then we have these sheets of lymphocytes. And they actually use this word sheets a lot. And this is going to be the dark surrounding that we see over here. It's caused by another B, Epstein-Barr virus, is going to sometimes precipitate Burkitt's lymphoma. And there's two forms. There's an endemic form that we have in Africa. So I think of B for people with black skin might get this. And specifically shows up in the jaw. And the next B is for boys. So it shows up in young children. It could be boys and girls, but I just thought B for boys. Now, there's also a sporadic version. This is more likely to show up in the pelvis or abdomen, but I believe more telling, more likely to see in the vignette is the endemic African version associated with the jaw. So 14. So 14 is the upregulated immunoglobulin heavy chain promoter. What's 8? 8 is the c-MYC. I also think of 8 as being like the smallest number of all the translocations, and I think of like an 8-year-old boy, like a young kid. So this is just how, you can memorize it or not. Okay, so mantle cell. So males. So this is typically showing up in males, and males are more aggressive, and so this is a particularly aggressive cancer. Again, we have this 14, bad motherfucker, M for mother, and then 11 is for cyclin D1. So this is going to be an oncogene. It's going to promote, push the cell cycle forward. And, so if I have this oncogene and I put it on this highly active 14 promoter for this immunoglobulin, I now have way too much cyclin D1, which pushes the cell cycle forward, which causes cancer. 11 plus 14 equals 25. And I thought to be a man at 25, that's when you can rent a car. So that's just how I remember that 11, 14 is associated with man, and men can rent cars. Follicular lymphoma, the two L's are associated with the L2 is how I keep this in mind. So follicular lymphoma, BCL2. And keep in mind that BCL2 stands for B cell lymphoma. I think of the menstrual cycle when I hear the word follicle. And the menstrual cycle is about waxing and waning of hormones. And so similarly here, the follicular lymphoma is a waxing and waning of swelling lymph nodes, much like the menstrual cycle. And then I think of the follicles and the menstrual cycle. I think of puberty. When does puberty really strike its hardest? Between 14 and 18 years old. So that's how I remember the 14 to 18. Diffuse large B-cell lymphoma. I'm seeing these double L's again. LL. Not the two L's of the cell. That's a cop-out because everyone could have, Burkitt cell lymphoma, mantle cell lymphoma, etc. So that doesn't count. L and L, large and lymphoma. Again, this is a BCL2. BCL2, keep in mind, is a anti-apoptosis gene. It inhibits back and backs from oligomerizing, which pokes a hole in the mitochondria, which dissipates the mitochondrial membrane potential, allows cytochrome C to come out, and causes apoptosis. It's anti-apoptosis. So if I have a gain of function mutation where it's overactive, or it's overactive because I put it on top of a, the 14 highly active promoter, I'm going to have way too much anti-apoptosis. That's what causes the cancer. I think of the word diffuse as being something is diffuse. It's kind of like everywhere. And so this is kind of everywhere in the sense that it's very common. That's how I keep this in mind. Marginal cell lymphoma, not as many fun ways to go about this. 11 and 18 is associated with chronic inflammation, MALT, mucus associated lymphoid tissue, lymphoma specifically. Remember that this was also caused by a H. pylori. So primary central nervous system lymphoma, people with HIV that has progressed to AIDS, if they get Epstein-Barr virus, this might cause a ring lesion in the brain. And this looks like toxoplasmosis. So I don't think you have to worry too much about it, but clinically we would want to differentiate it from that. All right, let's do a little overview of all the translocations between the leukemias and the lymphomas. 8 is the youngest, it's the smallest number. It's associated with Burkitt, which is associated with young boys. I think of BC, Burkitt, and then the C over here. And then remember that the 14 is associated with the immunoglobulin promoter, which is constitutively expressed. Immunoglobulin is 14 letters. And then we have bad motherfucker when we put all of these things together. And that's just how I keep in mind that we have. This is specifically for Burkitt, mantle, and follicular lymphoma. 922, the Philadelphia chromosome altogether is 22 letters, and that's how I remember that it's the 22nd chromosome. This is the BCR-ABL fusion. BCR is a particular gene, much like the heavy chain, which is upregulated hematopoietic cells, and ABL is just a receptor tyrosine kinase that is pro-mitosis, pro-division. So if I upregulate this by fusing it with a promoter, we're going to get way more division than we used to, which is why you get cancer. This shows up in two different scenarios. ALL, which is associated with the worst prognosis for adults who get ALL. Remember, ALL is normally for kids, but also, and probably more importantly, for CML is more classically associated with the 922 translocation. 11 and 14, remember that adds up to be 25, and I think, well, okay, men can rent cars at 25 legally, and man for mantle, and this is aggressive because men are aggressive, and it's the cyclin D1 with the IgG heavy promoter. Remember that is 14. 11 to 18, no way of remembering this. This is the marginal zone lymphoma. 12, 21, this is a mirror. 12 and 21 are mirrors. Mirrors go with minors. This is associated with ALL, which is for minors. It is a minor prognosis as well. It's not as bad as opposed to, like we said earlier, the 922 worst prognosis for ALL, which is often associated with adults. 14 to 18 is when, puberty might hit girls the hardest, and follicles reminds me of puberty. Remember that the lymph adenopathy is waxing and waning, like the menstrual cycle. And then we have these two L's for L2, BCL2, the anti-apoptosis, IgG heavy promoter, follicular lymphoma. Keep in mind that the BCL2 is a gain of function mutation as well on the diffuse large B-cell lymphoma. And I think of large lymphoma, again, the two L's. 15 and 17, acute promyelocytic leukemia. It is the version of AML that responds to the all-trans-retinoic acid because of the defective receptor, which is really just vitamin A, which does not kill the cells. It just induces them to differentiate so that the cancer goes away. Coming up with all of these numbers, I just was reminded of this funny little quote from South Park where you just felt like a conspiracy therapist, saying, Philadelphia chromosome is 22 letters, and that's how you can remember. It's just a little silly, but you know what? You got to remember it one way or the other. So whatever works. Histologies, let's do it. So we'll look at this one. Look at these little hairy projections. Boom, that is going to be the hairy cell leukemia. Look at these little owl eyes, clear as day. Reed Sternberg. Looking at these owl rods, which is the myeloperoxidase that is precipitated. Boom, this is going to be AML. A for owl rod, M for myeloperoxidase, also known as MPO. What is this? This is a beautiful thing. B for beautiful, B for Burkitt's lymphoma. I have these nice little pretty macrophages and these sheets. The word is sheets of lymphocytes in the background. This is Burkitt's lymphoma. Here I have these. This looks like an ugly smudge. Ugly smudge is associated with CLL. And then we have our teardrops. The teardrop is associated with myelofibrosis. Here I have like a bunch of casino chips, all of these red blood cells. This is the rouleau. Why are they sticking together? Because I have so many antibodies, and antibodies can agglutinate the red blood cells and cause them to stick together. Boom, done. One more section. Let's do it. Let's talk about chemotherapy. So we have some drugs that specifically will target DNA. These include these cell cycle independent drugs, which cross-link DNA. S-phase drugs, which interfere with DNA metabolism, G2 drugs, which mostly interfere with topoisomerase, except for bleomycin, and then the mitosis inhibitors, which target microtubules. Then briefly talk about immunotherapy drugs, very specific monoclonal antibodies that target, as an example, chronic myeloid leukemia has the BCR-ABL, so we have a monoclonal antibody that goes specifically for that, but doesn't really help for any other cancer. So that's what we're talking about in this brief section. And then we'll just go over the side effects. All right, so I'm from a less enlightened part of Florida. I have a lot of friends back home who think that we've cured cancer as scientists and healthcare workers, but that it's just too much of a profit motive that we're deliberately hidden the cure for the cancer. Although, first of all, like, what cancer? Because what cancer are they talking about? Because you just say cancer. Cancer is a very specific thing, and well, we do have a cure for some cancers. Most cancers in the stage 1 is like a 98% survival curve, as an example for breast cancer. But most other stage 1 cancers have a really, really high survival rate. So in that sense, you could consider that a cure. Something like testicular cancer, if you provide cisplatin, 95% 10-year survival curve. CML was a 22% survival curve. This was a really terrible cancer to get. It's over 90% survival with imatinib, which is just a simple pill that you can take. So it just seems a little bit silly to say that there's a conspiracy when we do have a cure for some cancers. On top of that, why just pick on cancer? Why not strokes? Is there another conspiracy for heart attacks? Why do those still happen? Or what about, autoimmune disorders? We haven't cured those. Or does every one of these have a conspiracy? Not to mention how much money, people could theoretically make from a cure for cancer. That is still very, you could absolutely capitalize on that. And also, why pick on the healthcare medicine, though? Why does my car break down? My car breaks down and they haven't designed a car that doesn't rust and doesn't wear out. Is that a conspiracy? So this is something as particularly strikes a nerve with me. I encounter a lot. So I don't know. I hopefully equipped you with one or two decent comebacks to, your home for Christmas at a bar and somebody brings this up. So a lot of cancer drugs, there's no perfect way to categorize them. You could, categorize them by target, categorize them by structure. And I think the best way to do it is, the cell cycle categorization, which honestly should just be rephrased as the DNA inhibitor. So the big takeaway from this is that it's a little bit tricky and there's going to be some overlapping categorization. So this is mostly how I'm going to be talking about them. These are all the ones we're going to be talking about in the next few slides. So again, this is cell cycle, but I like to think of this as DNA inhibitors. Everything here is specifically one way or another going to be dealing with the DNA and the creation, the separation, etc. So cell cycle independent. So I also don't like that name because there's tons of other drugs that are cell cycle independent but do not interact with the DNA. Nevertheless, you can think of this as a G0 or G1 but cell cycle independent. These are all going to be cross-linking the DNA. So we have the platinum agents. Why are they called that? Because they have the element platinum in them. And it's even in the name, cisplatin. This is used for testicular cancer. That's the one we said yields a really high 95% survival curve. This causes damage to the ears, damage to the kidneys, and you can prevent this toxicity by diluting it heavily. So just providing a chloride saline solution, or you can provide amifostine, which is just a reactive oxygen species scavenger, which can also help abrogate the toxicity related side effects. Then we have the alkylating agent. So notice that this is linking to the nucleotides itself, but it's not an alkyl group. It's not a carbon group. So the rest of these are also cross-linking, but specifically cross-linking through carbon groups. Busulfan, side effect is pulmonary fibrosis. Cyclophosphamide. So this is a nitrogen mustard. This was actually used during, I think it was World War I, actually, maybe not World War II. But I think of the two P's, cyclophosphamide, as PP. This is associated with everything with PP. The side effects, bladder cancer, hemorrhagic cystitis. So people urinating blood, Fanconi syndrome, causing issues with the proximal convoluted tubule, symptom of inappropriate diuretic hormone. All of this has to do with the bladder and the kidney and urine, and the two P's here remind me of those side effects. Nitrosoureas, carmustine and lomustine. Think of these must pass the blood-brain barrier. Because they pass the blood-brain barrier, they're good for brain tumors. But similarly, because they can get into the central nervous system, they are going to cause brain and spinal cord toxicity. Nothing really important about these next couple slides. I just had these leftover slides from the immunology and thought I'd recycle them. Cyclophosphamide, again, we have these two P's, has to do with bladder stuff, specifically because we create this acrolein metabolite as a byproduct. And note that it specifically links guanine bases too, and you can even see here that it does it through these carbon groups. S-phase inhibitors. So all of these are anti-metabolites that are going to interfere with the metabolism, the production of normal nucleotides. So the purine inhibitors, these only we're mimicking here. So azathioprine is converted to 6-mercaptopurine. So azathioprine becomes 6-mercaptopurine, and look at the structure here. It is just like all the other purines, so it will mimic and it will fit into the DNA structure, but it won't really work very well, and it will cause premature breaking and use up enzymes, and that's the mechanism here. We'll talk about allopurinol in a second and see how that, actually we'll talk about this right now. So how this is ultimately broken down is xanthine oxidase is going to break this down. But remember that xanthine oxidase also can break down uric acid. Where do we see uric acid? When people have things like gout or tumor lysis syndrome, I suppose. And so the allopurinol will prevent the formation of uric acid. So you can use that for gout, but it would similarly also inhibit this, which would cause this levels to increase, or at the very least they wouldn't decrease. And so then you could, this is something that could be bad and could be good, right? It depends if we want more 6-mercaptopurine in the body, or if we want to prevent the toxic side effects and we want the levels to go down. Cladribine is another mimic, but it specifically, I would know it goes for hairy cell leukemia as a target. The pyrimidine inhibitors then, the analog cytarabine, shown here. Now, inhibitors of thymidylation. 5-FU is going to be for, this is also an analog. This is also going to be a mimic, but I put this in a different section. I don't really think the categorization here is too uber important, but one of the things we need to do when we're going from a uracil to a thymine is at a methyl group, and we need to do that with THF. And to get THF, you need to use thymidylidate synthase. 5-FU shown here mimics the deoxyuracil monophosphate, but by mimicking it, it prevents this enzyme from working, which means, long story short, you do not thymidylate the uracil, you do not add the methyl group, you do not generate thymine. So 5-FU is a mimic. Specifically, though, it inhibits this enzyme. It has a side effect of hand-foot syndrome, which we've seen earlier, where you'll get swelling, blistering, pain in the hands and of the feet. Methotrexate inhibits dihydrofolate reductase. And we have all of this. This is kind of a beautiful picture over here. 6-MP and azathioprine is going to block the production of our purine, shown over here. Hydroxyurea is going to inhibit ribonucleotide reductase. And then methotrexate is going to inhibit the regeneration of tetrahydrofolate, which is necessary for the methylation, the thymidylation of uracil into thymine. And again, that's similarly how 5-FU works. Ignore this one. Methotrexate can be rescued by leucovorin, which we'll talk about right now. So I would know that methotrexate mimics folic acid, and aminopterin is another drug that works similarly. Leucovorin, again, is the rescue. So how does this work? Folate needs to be regenerated to tetrahydrofolate to add a methyl from uracil to make a thymine, and you need thymine for DNA synthesis, and you have a lot of DNA synthesis in the bone marrow. So methotrexate is going to inhibit dihydrofolate reductase, and now this could eventually get to levels where it's causing too much toxicity. So how can we overcome this? If you add leucovorin again looks really similar to folic acid. So the difference is methotrexate mimics, but it cannot be converted to tetrahydrofolate. On the other hand, leucovorin can and act as a stand-in. So if there's too much methotrexate and there's toxicity, you can add this, and you'll basically rescue the wild type phenotype by providing an alternative mechanism to thymidylate. So azathioprine, we've already talked about this, can become 6-MP. And 6-MP can be, so azathioprine becomes 6-MP. This is going to occupy the time of hypoxanthine guanine phosphoribosyl transferase, which is necessary for the salvage pathway of the purines. And, the purines? Yeah, no, the purines. I was right. The purines. And so that's the mechanism here. But again, we said that this is broken down by xanthine oxidase. Allopurinol used for gout, or maybe for the tumor lysis syndrome, would inhibit this, which would prolong the effects, extend the effects by increasing the concentration, preventing the breakdown there. G2 inhibitors, so all of these are going for topoisomerase with the exception of bleomycin. I think a bleomycin is blowing up the DNA. It induces a lot of reactive oxygen species, which breaks the DNA. This is associated with pulmonary fibrosis. I remember the two Bs, busulfan and bleomycin, both are associated with pulmonary fibrosis. Doxorubicin is another antibiotic. This will intercalate the DNA, and this inhibits topoisomerase 2. This promotes cardiotoxicity as a side effect. For the topoisomerase specific, so this intercalates DNA, which inhibits topoisomerase 2. But we have things that specifically go for topoisomerase 1 and topoisomerase 2. The irinotecan and topotecan. I always thought of Tekken as being the number one video game in like the early 90s. This is Tekken the video game. And topoisomerase 2, there are two sides to every story, etoposide and teniposide. Topoisomerase 1 is just going to cut. You can kind of, if you zoom in here, see it's just cutting one strand. Topoisomerase 2 cuts, well, 2 for cutting two strands. It cuts both strands over here. Whether you cut 1 or cut 2, it is usually going to result to cell death if you cannot relieve the tension of these supercoils. The mitosis phase inhibitors. So something we need to do during mitosis is the mitotic spindle need to extend out from the centrioles at the either end, the polar ends, opposite ends of the cells, and then bind onto the kinetochores of the chromosomes. I wonder later if we're listening to this, how much you can hear. All my friends are watching Aliens 2 at full blast in the other room, so hopefully it's not too loud, but I can hear it very loudly. This is their version of quiet, so I got to give them kudos, I guess. Anyways, M phase, mitosis. We need to extend the microtubules. They grab onto the kinetochores, and then we pull them back. That's what separates the sister chromatids. So this is just a classic thing we see with microtubules, is that they can extend out, they can grow, as shown here, continue growing. That is going to be the growth phase, but then the catastrophe, and then rescue, just meaning they come back out again. So elongating, polymerizing, and then shortening, depolymerizing is a necessary function of microtubules. Vincristine and vinblastine will inhibit microtubule formation. So here we see the vinca alkaloids, really just vincristine and vinblastine, binding to these dimers. And what they do is once we have them incorporated in the microtubule polymer structure, kind of like if you guys remember from the DDNTPs of Sanger sequencing, dideoxy, same thing's going on here. Is once they can be incorporated, but once they're incorporated, nothing else can be incorporated. So we cannot we cannot elongate any more microtubules. This is associated with peripheral neuropathy. Opposite end of the spectrum, paclitaxel inhibits the opposite, inhibits microtubule disassembly. So here's my microtubules, and now the paclitaxel binds. It hyperstabilizes them, and it prevents the depolymerization. This is not a good thing, right? We need them to become unstable. We need them to fall apart. That is part of their function. By them falling apart, they get shorter and shorter and shorter, and it pulls the chromatids away from the metaphase plate and towards the centrioles on the far end of the cell. All right, immunotherapy. We have this cell receptor called PD-1, programmed death receptor 1. This is kind of like an off switch for a T cell. And then we have, forget a tumor cell. This should be like an antigen. So I'd imagine this is APC or a tumor cell. So a normal cell might go ahead and upregulate PDL1 and PDL2 to bind to the P programmed death receptor 1. This binds to it and basically turns the T cell off. What's the point of this? It's basically, if you had a normal cell that's getting attacked by a T cell, it might go ahead and hit the off switch, the self-destruct switch on the T cell. We want to prevent autoimmune disorders, and this is the way that your body naturally does this. Cancer cells take advantage of this self-destruct button, though, and they're going to upregulate the bejesus out of this protein, so they're always going to hit the off switch, even when we, of course, don't want hit the off switch hit. So this is bad. So the therapy here is pembrolizumab. Pembrolizumab is a monoclonal antibody, as we can see by the term MOB over here. And this is going to bind to the PD-1 receptor, and we are going to inhibit it so that we're inhibiting the off switch, so you cannot turn the T cell off. So the T cells will do their job. Maybe you'll get some more autoimmune syndromes in the process, but it's a trade-off. Do you want cancer? Do you want autoimmune syndrome? So alternatively, we can look at the PD-L1, the receptor, the finger that's pushing the button to turn off the T cell. Tumor cells, we said, will upregulate this. So alternatively to turning off the off switch, we could just turn off the finger that pushes the off switch. So we have a bunch of things. Atezolizumab, durvalumab, and avelumab are all going to be inhibiting the PD-L1 so that you cannot activate PD-1, which is going to kill the T cell, because we want the T cell because we want it to go ahead and kill our cancers. And then CTLA-4. So we have co-stimulation, if you think back to the immunotherapy, the immunology section. So CD28 is usually needed to bind to B7 for co-stimulation to activate a T cell. However, sometimes these receptors, CTLA-4, are upregulated, and they can bind to B7. So CD28 is the on switch. This is the decoy on switch. So if CTLA-4 binds, the T cell is not going to be activated. We need the CD28 to be activated. So the cancer cell is going to take advantage here, and it is going to induce the T cell, so that the tumor cell here is going to cause the T cell to make tons of CTLA-4, which are going to bind in lieu of the CD28. So the T cell never gets turned on, so it cannot kill the cancer cell. Pretty sneaky. So ipilimumab is going to go ahead and bind to the CTLA-4. And so if I bind and inhibit this, then the C28 is cleared for binding to the B7. Other sort of random drugs that are usually going to be very cancer specific. Bevacizumab is going to be a VEGF. Remember, this is for angiogenesis. Cetuximab is for head and neck cancers against epidermal growth factor receptor. Imatinib is going to be for the BCR-ABL Philadelphia chromosome fusion protein. Again, this is a pill. Rituximab is going to be for CD20. Remember that the 1 to 8 is for the T cells, and then like the 10 to 23 is going to be for the B cells. So this is going to be good for B cell leukemias and lymphomas, which again is most of these are going to be B cells. T cells are a minority. Tamoxifen and raloxifene are going to be for breast cancers mostly. So these are SERMs, selective estrogen receptor modulators. So these act as antagonists in breast tissue. So if I had an estrogen receptor positive breast cancer that's sort of like drunk on estrogen, it requires estrogen for its growth, and I put in a bunch of tamoxifen is going to bind to that receptor, and it doesn't do anything, but it's taking up the receptor. So now the estrogen can't do its job in promoting the growth of the cancer cells. So this is good therapy in that sense. This also acts as an agonist in bone. So when females go through menopause, they no longer produce estrogen. Estrogen is necessary to inhibit osteoclasts. If you don't inhibit osteoclasts, they degrade too much bone, and this is causing osteoporosis. So this could prevent osteoporosis in postmenopausal women. Problem though, endometrium is also very receptive to estrogen. Tamoxifen is an agonist here. So notice this was an antagonist and this is an agonist. They are both agreed in that sense. They differ on what happens in the endometrium. Tamoxifen is an agonist for the endometrium. It causes endometrial growth, which can cause endometrial carcinoma. Raloxifene, on the other hand, is an antagonist at the endometrial level. So it can have the benefit here and the benefit here, but it will not, pose as a carcinoma risk in the endometrium. And then trastuzumab is the brand name for her. Herceptin is the brand name for trastuzumab, which is a Herceptin 2, also known as ERB2 receptor of breast cancers. Remember earlier we talked about like triple positives. You can be estrogen receptor positive, progesterone receptor positive, and then Herceptin positive. So triple negative, triple positive, or some combination there. So Herceptin positive cells will be very responsive to this. Side effect though is cardiotoxicity, specifically dilated cardiomyopathy. So the side effects for cancer, we're probably used to this. We've all had a friend or a family member who's unfortunately gone through cancer. We've seen it on TV shows. Cancer, these drugs are going for the rapidly dividing cells because they're going for the DNA. They're inhibiting the cell cycle. Usually, hopefully cancer, but skin, hair, GI, bone marrow stuff. So, if we look at the GI issues, nausea, vomiting, loss of appetite and weight, abdominal pain, diarrhea. We look at the skin, rash, changes in skin color. If we look at the bone marrow, fatigue because you're not making red blood cells, bruising and bleeding because you don't have platelets and your superficial bleeds are going to be worse. and infections because, yes, maybe we have a lot of white blood cells if we have a myeloid leukemia, but they might not be effective, healthy white blood cells. And then the hair is going to be associated with alopecia. Now, very specific side effects, which are going to be much more, again, this is kind of generic, expected because we're inhibiting any cell that's dividing too much, and then these are uber specific. Cisplatin, ear, kidney toxicity. Nitrosoureas, carmustine, we must get into the central nervous system, and therefore it's good for brain tumors, but it also causes CNS toxicity. 5-FU, hand-foot syndrome, also known as erythromelalgia. Bleomycin and busulfan both cause pulmonary fibrosis. Herceptin causes dilated cardiomyopathy. Doxorubicin, remember, this is going to be an intercalator of topoisomerase. It is a G2 inhibitor, is an antibiotic. It's good for cardiotoxicity. Cyclophosphamide, remember the 2 Ps for PP. This is associated with hemorrhagic cystitis, bloody urine, which can also be SIADH. Just anything associated with the bladder or the, Fanconi syndrome, things like that. Vincristine inhibits microtubule growth associated with peripheral neuropathy. And tamoxifen, remember this is one of those SERNs, selective estrogen receptor modulator. In the breast cancer, it's an antagonist. That's why it works as a chemotherapy for breast cancer. For the bone, it acts as an agonist. This is good for postmenopausal women who need estrogen to inhibit osteoclasts. But remember that the tamoxifen in the endometrium is also an agonist, like it is in the bone. And so this can cause excessive endometrial growth, which can be associated with an endometrial carcinoma. And lastly, but not least, just a couple terms. If you hear the word adjuvant, this means that something was delivered after the primary treatment. So usually the primary treatment is surgery, not always, but adjuvant chemotherapy would be chemotherapy after surgery. Adjuvant, radiation would be radiation after the primary surgery. And the neoadjuvant means that for whatever reason, we thought it was a good idea to shrink the tumor with, radiation, chemotherapy, or a chemo-radiation therapy combination to shrink the tumor. That was to be done to shrink it before surgery, and then we cut it out. So for whatever reason, maybe it's a better idea to shrink it before cutting out. And in other cases, we want to cut it out and then try to hit the leftovers. And of course, you could do a combination. You could shrink surgery and then hit it with more radiation and chemo. All right, hope that was helpful. Good luck to everybody on your 2 upcoming tests. All the best.